Hello, my name is Richard Gerardo. I'm a chiropractor in Burbank, and I also have a practice with a dentist, David Shirazi, in Thousand Oaks area, in that region. As you can tell, I'm not really Richard Gerardo, but he's on a train right now, and I'm standing right here. So we're gonna move forward. It's an interesting case dealing with the issue of generalized hypermobility. That's why I talked about what Dr. Shelley had presented with that cervical traction and its relation to generalized hypermobility. He is in Burbank. So we're going to discuss the issues of generalized joint hypermobility and how it relates to joint laxity, and it's present in approximately 10 to 25% of the population. It can be caused by acute ligamentous injuries, overuse injuries, and can be increases with fractures and any sort of degenerative joint disease and excess motion. So it's actually it's either a syndrome, it's hereditary, or it can be acquired through poor diet and things like that. But it's a major issue that needs to be considered with treatment. And since again what Dr. Sorolla presented regarding the SI joint and its instability, and what Dr. Pine presented with regard to the study of what's going to happen regarding finding out how we treat issues of SI joint hypermobility or fixation, it's an issue that needs to be addressed. There was a questionnaire produced by Hackham and Graham. It's a very simple one, other than just, so I think combining the cervical distraction and pre and post testing that, there is a questionnaire. It's just five part. There was an 84% accuracy with just 2 questions out of 5. If they answered yes to, it means they have that sort of syndrome. So it's really simple to use. And the questions are, can you now or could you ever place your hands flat on the floor without bending your knees? Can you now or ever bend your thumb and touch your forearm? As a child, did you amuse your friends by contorting your body into strange shapes so you could do the splits? As a child or teenager, did your kneecap or shoulder dislocate on more than one occasion? And do you consider yourself double jointed? If you said yes to any of these 2 questions, it's likely you have some degree of a generalized hypermobility syndrome. So with regards to the TMJ, we know that it's a pretty intense situation, particularly when it's a disorder, and it's a multifactorial condition. It's associated with biopsychosocial issues, so there could be biological contributions, psychological contributions, or how the body's been used. Auto accidents, things like that can create that, as well as mechanical implications. So what you're doing with your teeth and as you chew, and what happens to the jaw, and how the musculoskeletal system works together. And it's associated oftentimes with muscular hyperactivity. Times like bruxism or clenching is associated with, they call this parafunctional behavior. It can even create, due to this dysfunction, generalized hyperactivity in the whole body. It can start causing particularly cervical spine disc problems, because you get forward head postures associated with airway dysfunctions that are associated with the TMJ. So these all work together. And it affects the occlusion, the way the teeth touch, the health of the teeth, because if you're starting to bite down and grind and clench, you're going to have changes in the roots and where the periodontal issues. It's going to be a real far-reaching issue, as well as airway space issues, which are really huge, because we're finding the TMJ is associated with sleep apnea, and loss of oxygenation has a far-reaching effect on all kinds of things: diabetes, heart disease, all kinds of things that are rampant throughout our population at this time. According to Hirsch and his co-authors, they found generalized joint hypermobility is a predisposing factor for TMD. And they found that individuals with this GJH, or generalized hypermobility, have a higher risk of developing reciprocal clicks, popping on both sides when they're opening and closing, the joint dislocating at times, so you get sort of opening locks because the jaw, it goes too far forward, and they have a risk of a lower risk of mouth opening limitation. So one of the things that was interesting when I'm trying to figure out, how could it be a problem if what we consider most of the problem with TMJ is they can't open their mouth. We're finding with the people with hypermobility issues, they have such wide degrees of movement that even when they have problems with their jaw, even with a closed lock where it's like it can't open it very well, they have such hypermobility they can still get some opening, so it looks relatively normal. So with someone who has this generalized hypermobility syndrome, they could actually have a relatively low end of normal, but the joint could be completely out of position and be dysfunctional, and you start getting secondary problems in the neck and spine. So Whitaker's noted that hypermobility by itself does not affect the TMJ unless there's a movement dysfunction, such as a click or a joint lock, and the parafunctional aspects with hypermobility with the TMJ can be worse, since the condylar translation happens with a higher pressure because of joint overload. So because they can have some movement, but the joint starts getting stressed more because of this hypermobility. We're finding that healthcare professionals and patients understand TMJ hypermobility, the more we believe if they understand more about it, then the contributions will help with regards to developing a preventative approach for treating of temporomandibular joint disorders. So hypermobility issues should be considered a standard diagnostic component of dysfunction. Let me just ask them those 5 questions, or do the cervical traction test as part of our evaluation. So there's a 47-year-old female presented in 2010. Chief complaints were pain, chewing, jaw pain, limited mouth opening, and TMJ crepitus. She had trigger points, tenderness of the masseters, trapezius joint, and the capsule, joint capsule of the TM with open and closed, and the cervical spine. They found a displaced disc without reduction on a CT scan on the left side with DHG. She started having certain adhesions and arthrosis in the joint, so the joint wasn't even translating very well. It was pulling to the left as she opened, and that's one of the things you look for after they open the mouth and the jaw opens and pulls to one side and doesn't center and then closes. They'll pull towards the side of the arthritic joint and the adhesions, and it's much more serious than one that opens and then centers. This is kind of what it looked like on CT imaging. You could see that is moving on this side. It wasn't quite moving so well. There's something called motor reflex testing that is used by the dentist, Dr. Shirazi. He studied with the doctor. I'll come up with his name. I can't. Anyway, he studied with a doctor who specialized, Dr. Almos, who specialized in treating TMJ-related issues and working with chiropractors. And one of the things they do is certain muscle testing to differentiate where they're dealing with an ascending problem coming from the feet, spine, pelvis up to the jaw, or from the jaw, cranium down to the spine. And so he put together a repositioning appliance. And a day and nighttime appliance. It was worn 24 hours by the patient, and because of his findings that there was an ascending component, he referred him to Richard Gerardo for chiropractic treatment. Richard found that she had pain in the jaw, left leg, right hand issues. She had a fracture at T7, T8 that was healed. The cervical compaction test indicated that she was cervical primary. Lumbar range of motion in the cervical region were reduced by at least 10%. SI joint was found to have hypermobility issues, and she required a sacroiliac support belt. He likes working with Dr. Sorola's SI belt. He found it very helpful. In the first 2 months of the treatment, focused on the SI hypermobility syndrome, thoracic, cervical, and craniomandibular manipulation. However, the patient became very sensitive and didn't really want chiropractic manipulations, and decided that she didn't want any further care. She just wanted to go to a masseuse. So that's what she started doing for the next 5 months, got massage. However, the problem was she was also seeing the dentist and wasn't getting better. So at the 5-month part, the dentist said, look, if you want me to help you, you have to go back to the chiropractor because you're not getting better. If anything, you're getting worse. So the patient, balked on it, but then decided, well, he said, look, I can't guarantee the care, and if you don't do it. So she went back to start to see Richard again. And she started improving. As she started getting some improvement, one of the things they started finding is they had to find some way of increasing the stability in the retrocondylar tissue. So the retrodiscal tissue was too loose. And so as she would open, the disc would get pulled forward. As soon as the external pterygoid muscle opened, it jerked the disc forward, and the retrodiscal tissue wasn't letting it out slowly. And so what they started doing is doing prolotherapy shots into the discal tissue to start creating some adhesions to create some stability. And there was some about to create stability, but also some scarring. So they did 4 treatments with procaine alone, and 6 treatments with dextrose and procaine, and then increased the dextrose concentration to 25%. So initially what they're doing is trying whatever they can do to break down any adhesions. Then as the adhesions improved, they were more concerned with how the jaw translated. So in general, what Dr. Shirazi says, when there's purely anterior disc displacement, the injection's in the posterior joint, as in this case. If the joint is medial or anteromedial, then he gives it more posterior lateral to sort of draw the tissue back. What was happening was he was using Dr. Gerardo's indication of when the joint was moving properly, when the neck, jaw, and cranium was in good balance. Once it was in good balance, he would then say, okay, give the shot now. And so that's how they would work together, and Dr. Shirazi would wait until Dr. Gerardo would say, it's time to do it, it's safe, it's in good position. And so when they found this optimal position, that's when they would do the shot. Initially the left TMJ was not moving adequately, and then it started improving, and the patient was initially going to be referred prior to this process to an oral surgeon for arthrocentesis, but she did not want to have that done. So she kept on with care longer than it probably might have been needed, but she was getting some improvement and she wanted that. And the end results was she increased from 27 millimeters of an opening to 42 millimeters of an opening. She was completely pain-free. She had full range of motion in the lumbar and cervical spine. And she's treated bi-weekly, every other week, to maintain stability and position of the disc, so because she has a tendency to clench and sort of bring it out. So as she's improving, the treatments has been continued. So in general, whenever there's a chronic disc displacement without reduction, there are strained stretched ligaments in the posterior joint space, and manipulation can reduce the disc, but if it doesn't stay in place, if it keeps on loosely moving forward and you're doing everything right, sometimes prolotherapy may be indicated to help strengthen and tighten the posterior band of ligaments. The patient's condition necessitated long-term ongoing conjoint dental chiropractic care to reach a successful outcome. It's possible that if the patient had the arthrocentesis, they would have moved faster. However, they determined they didn't want to run the risk of having that type of procedure. Hello, my name is Richard Gerardo. I'm a chiropractor in Burbank, and I also have a practice with a dentist, David Shirazi, in Thousand Oaks area, in that region. As you can tell, I'm acute ligamentous injuries, overuse injuries, and can be increases with fractures and any sort of degenerative joint disease and excess motion. So it's actually a kind of, it's either a syndrome, it's hereditary, or it can be acquired through, poor diet and things like that. But it's a major issue. Not really Richard Gerardo, but he's on a train right now, and I'm standing right here. So we're gonna move forward. It's an interesting case dealing with the issue of generalized hypermobility. That's why I talked about what Dr. Shelley had presented with that cervical traction and its relation to general. It needs to be considered with treatment. And since again what Dr. Sorolla presented regarding the SI joint and its instability, and what Dr. Pine presented with regard to the study of what's going to happen regarding finding out how we treat issues of SI joint hypermobility or fixation, hypermobility. He is in Burbank. So we're going to discuss the issues of generalized joint hypermobility and how it relates to joint laxity, and it's present in approximately 10 to 25% of the population. It can be caused by acute